Hey everybody, welcome to BFR Tuesday. Let me get myself centered here. Hope everybody's doing well. Let's see. Anybody have any questions before I get started? Today I'm going to go over a simple worksheet that I use in my courses. So it's kind of got, based on what we did last week, which was the algorithm, this has just kind of a summary of the things that you kind of need to do and have in order to initiate BFR in the clinic, and then also an idea for what you could use for a day sheet or kind of a log for what you're doing and what you need for each patient. Before I get started, I usually like to ask if there's any questions specifically of me so that I can answer that. And if not, I'll give it about a minute. And if not, then I will progress to what I plan on talking about today. All right, no questions. So let's go to sharing my screen. All right, screen share. Hopefully everybody can see. All right, so here is, and I've included this. I believe I have this up there already. Let me just double check. I thought I shared this. If I didn't share it, I will. Let me stop sharing, and I'm gonna make sure I got this thing. Okay, so I just shared it, and it should be there now, so you can download it. Apologize, thought I had done that. Okay, so let's share the screen again. Share. All right. Here we go. So BFR worksheet. What we do during our live classes that I teach and the guys that teach for me, we go through this throughout the day. So what we're looking at is, your basic setup, like what do you need? And what we need to know is what cuff size to use. This is specific for the smart cuffs because that is the education that I've written for. But this would apply to any cuff that you're using, making sure that you have the cuff size. And so again, this is around the smart cuff tooling. So depending on the limb size, it will determine what size cuff you need. You don't want it too big because then you have to inflate too much. You don't want it too small because otherwise you don't get circumferential enclosement. Pressure recommendations, usually in our first phase of exercise, and this would link back to our algorithm. We have our passive cellular swelling, meaning that the patient's not doing anything. Like today, I had this for a patient that I did this on somebody that has a third metatarsal stress fracture, lacrosse player. So I did a passive cellular swelling in the lower extremity. We did 80% limb occlusion pressure because she could tolerate it. The next time I see her, I will add some isometrics. And maybe even some quad work. Depends on what she can tolerate, but I'm going to push them as far as they can go. I could have done some upper body ergometer with her today. I just ran out of time. By the time I did limb occlusion pressure, got her oriented, had done my evaluation, I was ready just to get right into those passive cell swell protocols. You see here, phase 3, we have the isolated exercises, we have compound exercises or multi-joint. This will tell you what your limb occlusion pressures should be. Here, 40 to 50% in the upper extremity, 60 to 80% in the lower extremity. Again, same thing here, should be 40 to 50% limb occlusion pressure in the upper extremity, lower extremity is going to be 60, 80. That never changes. Limb occlusion pressure is always the same, except for ischemic preconditioning. Ischemic preconditioning is 100% limb occlusion pressure, and I tend to do that prior to exercise or heavy eccentrics. Heart rate reserve, this is how you calculate your heart rate reserve. And what I forgot to mention is here's your quick reference LOP chart. So once you find your limb occlusion pressure, you can quickly and easily get your 50% LOP or 80% LOP. I would recommend having this chart in a larger PDF laminated by your Doppler, so that way you can quickly and easily grab those. And this is what you're going to chart in your electronic medical records or your medical records. Is what LOP you found and in what position. I also recommend getting a LOP in whatever position you're going to exercise in, standing or lying or seated. Heart rate reserve is what we use for aerobic capacity training. So you get their resting heart rate when they get out of bed, what their max heart rate is, 220 minus their age. Their max heart rate minus their resting heart rate is equal to their heart rate reserve. Multiply their heart rate reserve times 0.3. Add back their heart rate at rest, and that will give you your training target zone. I've done a few different webinars on doing aerobic capacity training. And this is typically in either a moderately fit person or an unfit person. In a super fit person, like an elite cyclist, this protocol won't be enough to move the needle for them, so they need to go more into performance. And I'll be hopefully releasing our performance course online in the next couple months. When we are training isolated exercises or compound exercises, we want to work at a specific 1 rep max or a percentage of our 1 rep max. 20% 1 rep max is a good starting point. And so here is an example of how to calculate your 1 rep max. So if you know somebody's 10 rep max, then you would multiply that weight that they could do 10 times, multiply that times 1.33 in this chart. That will give you your estimated 1 rep max, which in this case on a 100-pound bench press for a 10 reps is 133-pound 1 rep max. Multiply that number times 0.2, which equates to about 27 pounds. That would be your starting load for weight training. Now, a lot of times in rehab, we don't have the luxury of knowing what a 1 rep max is. So instead, what we do is just take them to as close to failure as possible. And I estimate based on those 30 rep, 15 rep, 15 rep, 15 rep protocols. So a lot of times in my first visit, I'll just have them do open chain, no weights, like just see how they do. And then if they can tolerate that, then the next time I can kind of cook them a little bit more. What you'll see here is my travel card. Their name would go up here, that they signed an informed consent would go here. Here's your basic setup. What's the limb cuff size? What's their LOPs? I would recommend doing this all in one visit, like the first visit, like I did today. That way you have it done. Like you just know what it is and you can just get to it. And then what you can do is you can put the date, what protocol you want to use, what's their target training zone, or if they're doing aerobic, what's their target heart rate, and then what exercises are you going to do? And you could do this throughout. REP should actually be RPE, rate of perceived exertion. I want to get them to about a 7 or 8 out of 10 rate of perceived exertion. That means that the pressure is right and the weight is right. I don't mess with pressures too much. I let the pressures do what they do, which is I think you get better results with higher pressures. So I tend to be at the 50% upper extremity, 80% lower extremity as much as I can. What I do mess around with is resistance. What's the load that I'm going to use? And so I want to get them to about an 8 out of 10 rate of perceived exertion. And then I know we're going to get probably a pretty positive outcome. If you look down here, I kind of summarize this a little bit better, I think, for you. Strength and hypertrophy, isolated, compound, and or compound. The only thing I didn't put in here that I think I actually did update this card, I gave you the older card, but it's close, is isometrics. If they can go somewhere between cell swell, but they can't quite do isolated or compound exercises without getting 5 out of 10 pain. So there's somewhere like 2 or 3 out of 10, but cell swell is too easy. Then I'll do an isometric. Then I'll do an isometric hold at 1 minute at 50% lower extremity or 50% upper extremity, 80% lower extremity LOP, 1 minute on isometric, 1 minute rest, 1 minute on, 1 minute rest, 1 minute on, and then deflate. So about 3 rounds of isometrics seems to be enough to fatigue them. Again, it's all about fatigue. So if you don't have the weights quite right, just get them to fatigue, but not to failure. Remember, we go to failure, we cause damage, and I'm trying not to cause damage to these tissues. I do like the BFR, especially in the earlier phases with isometrics and light load, because it allows us to start simulating high intensity exercise. But there's also a huge pain reduction component, and they feel like they're doing something. So if athletes psychologically feel like they're more engaged with their rehab. That's purely anecdotal. But now after doing this for about 3 years, I can say that is it's, I mean, as true of a statement as I can say without any research to support it. All right. I've had 0 clicks on my handout. So what questions does anybody have for me? Any questions regarding the day sheet or anything that I talked about? But really, that's just a summary of everything that we talk about as a programming protocols. Anything at all? All right, great. If there's no questions, I'm going to let you run with that, and feel free to reach out to me at edlacara.com. Happy to answer any questions. And otherwise, I will be back next week with hopefully something else to share that is of interest. But of course, I love getting feedback, because then I know what people have questions about and what I can answer. Thanks so much for joining me. I like to keep these things short because I am in between patients, and it is my lunch half hour before I see somebody else. So I'm going to call it, but let me know how I can help. Be well, and thanks for what you do, helping people stay and become more active. Bye for now.